Good afternoon, everybody. This talk is mainly to draw attention to an upcoming major epidemic, that is uh, arrhythmias occurring in repaired CHD long term after the surgery. As we know, 2.5 million adults are now living with congenital heart disease in the country. Many children operated in the 1990s now have transitioned into adulthood. Even now, many adults with congenital heart disease are getting operated late in life. Many children are getting later surgeries, and the overall survival of surgeries done in neonatal and infanthood are also getting better. So the number of adults with operated congenital heart problem are increasing in India. A significant incidence of arrhythmias, atrial as well as ventricular arrhythmias, and few instances of sudden cardiac death in these operated as well as unoperated adults has been noted. There is a steady rise
So, Dr. Atul,
in the number of the patients with arrhythmias after surgery. It has been seen that almost 50% of patients operated after the age of 25 for ASD, and around one-third of the patients operated tetralogy of Fallot develop atrial tachyarrhythmias.
Yeah, Dr. Atul, can you hear me?
Yes.
So actually, this session was supposed to be 12 to 15 minutes time. This video is running for 30 minutes. I would request you to kind of, shorten it and give us the gist of your presentation. You can directly jump to the post-operative arrhythmias and tell us what you want to tell. Would that be fine?
Yeah, sure.
Know from where to start this video, and we can straightly jump to that point and
just go to the mechanism, because that's one thing which people need to understand. The examples straight away.
Next 30 seconds. Yeah. Okay, keep going. Yes, from here. Yeah, okay, play. And then in between, whenever you tell us, we'll pass forward. Okay. Yeah. Please go ahead, sir. Thank you. Sorry for the interruption.
Some areas like the surgical scars over the ventricles, the suture lines, and the patches work as anatomical barriers. They also modify the existing the conductivity properties of the existing myocardial tissue. If long-standing heart failure is present, there is ventricular dyssynchrony is a high risk for developing future arrhythmias, and associated coronary artery injury, ischemia, and other features are a major cause for development of arrhythmias in the future life. The post-operative substrate of the CHD. What exactly happens is the sinus node dysfunction and AV block is seen in certain specific conditions, as in atrial switch surgeries, Fontan, single ventricle, in rerouting of partial pulmonary venous return. So in these surgeries, mostly sinus node dysfunction would be seen. In some other specific surgeries, you may see macro reentrant atrial tachycardias, which is basically atrial tachycardias which have a reentrant mechanism. Focal atrial tachycardias who have a focal origin, presence of accessory pathways, which could be there in even in normal hearts, but in presence of a CHD accessory pathways tend to manifest into SVTs earlier. Ventricular arrhythmias in the form of frequent BPCs, bigeminy or couplets, etc., um, developing into monomorphic ventricular tachycardia, and finally polymorphic ventricular tachycardia. Now, which lesion has a preponderance of developing the Fontans? These are the more likelihood of developing atrial arrhythmias in the form of either intraatrial reentrant tachycardia or atrial fibrillations. The TOF repairs also are high risk for developing ventricular arrhythmias, and so are long-standing LVOT obstructions like AS with LV dyssynchrony. Ebstein's, as we all know, has a high chance of having multiple accessory pathways, which results in intractable paroxysmal SVTs. Again, many arrhythmias have typical association with certain CHGs, and we've seen mostly this intraatrial reentrant tachycardia as being commonly associated with postoperative Mustard, Senning, and Fontan, and also with any surgery which requires a long atriotomy has the potential to develop a IART in the future life. Similarly, AF can be seen in mitral valve, aortic valve issues, or in unrepaired single ventricle due to long-standing pressure on the left atrium. Ventricular tachycardia is mostly seen with tetralogy of Fallot repairs and few with AS with significant dilated cardiomyopathy like LV dysfunction, and in patients with heterotaxy, there is congenital sinus node dysfunction seen in post-operative Mustard, Senning, or univentricular palliations. Acquired sinus node dysfunctions can also be seen. This chart classifies the cardiac defects into simple, moderate, and complex. And if you see the complex have higher incidence of AT, AF, and all sorts of arrhythmias. So as the condition increases, it is seen that the preponderance of post-operative arrhythmia is known to increase. And with our past few years of performance in across the country, a lot of complex are now surviving and going into adulthood. So the number is going to go up. It's important to know what exactly causes these arrhythmias, because this is a particular specific substrate. Now, a post-operative patient has a scar. How does a scar manifest into arrhythmia? So most of these patients will have an atrial scar because of the atriotomy. Now most of the surgeons now avoid ventriculotomy unless absolutely necessary, and this approach has reduced the incidence of ventricular tachycardias, ventricular scar related arrhythmias. So when there is a scar, all that we need for arrhythmia to start is, as we know, a unidirectional block across two channels of different conducting velocities. So there is a fast channel and there is a slow channel, and you just need a unidirectional block across one of the channel to allow for return of the impulse through the other pathway, so that a circuit is established and there is a re-entrant tachycardia. So in most of these atriotomy scars, these circuits can come across either the scar or the crista terminalis or the natural barriers such as the tricuspid valve annulus or the mitral valve annulus or pulmonary vein orifices, which are generally the barriers to conduction, which manifests into say something like atrial flutter or intraatrial re-entrant tachycardia. In ventricular arrhythmias, the mechanism is slightly different, although the scar and the anatomical barriers together form is a channel for the impulses to travel through. The margins of the patch develop the scar and also provide the channels for the impulse to travel across. The pulmonary valve, as seen here, and tricuspid annulus, they are natural barriers. So the impulses don't go beyond that, and anything coming in this form has to go across these channels and go return again through the same pathway. So basically, this results in a sort of a re-entrant pathway for the ventricular muscle. So this is shown in the diagram, where you see that between the anatomical barrier, which does not have electrical conduction, and also the scar, which is relatively inexcitable, there is a pathway of slow conduction, and the loop outside has a fast or a relatively faster conduction across the healthy myocardium. So the impulse would enter from here and exit from there, which creates an entry point and an exit point across the scar. And what exactly happens is the manifested VT is based on the exit point. What is the morphology depends on the exit point, but it may have generally done to terminate the tachycardia. Those areas could also need to be. There is loss of chronic hemodynamic tachycardia and also of sudden cardiac decay. As we have discussed before, the narrow conduction, there is a the slow conduction is 32 times exercise stress test, echocardiogram. Those patients who are also on medication, ventricular tachycardia. As you can see, old lady with VSD closure and who had recurrent supraventricular tachycardia. As you can see, so broad complex tachycardia with underlying aberrancy, and you can see the P waves. So it's like a long RP tachycardia. This patient was taken to the EP lab, and there was a macro reentrant atrial tachycardia at the level of the atriotomy incision. The ablation was done through this slow conducting isthmus, and resulting in the termination of the tachycardia, and also the cavotricuspid isthmus was ablated to complete the um, ablation line and prevent the recurrence of the tachycardias. This case was that of a 23-year-old boy with Rastelli repair in China. He had ventricular tachycardia, which was rotating around, or it was rotating around the RVPA conduit. So here you can see the activation sequence of the ventricular arrhythmia in this boy, and this is like a entry point and the exit point with the with the tachycardia going anti-clockwise here, and another tachycardia which was activated where the previous exit point became the entry point, and the previous entrance became the exit, and then it was a clockwise tachycardia. The it was mapped and ablation was performed in the slow conducting isthmus area. So this was like a periconduit uh, activation of the myocardium leading to ventricular tachy. So another case of a 32-year-old lady who had a secondum ASD closure at 12 years of age and who had a persistent left SVC, had severe palpitations. And as you see the adenosine ECG which was given, this is the tachy ECG, whereas this was the adenosine ECG, and it showed P waves, although the tachy did not terminate, but it showed discrete P waves, suggesting that this was atrial tachy. And when we mapped this atrial arrhythmia, we found that the lady had a dilated coronary sinus with a large left SVC, and the origin of the tachy on the electroanatomic maps was noted to be the superior end of the of the coronary sinus, which was ablated, and this is generally the point where the vein of Marshall is also seen to be attached, and it's interesting to note that although innocuous it may seem that left SVC and CS, isolated left SVC is also nowadays known to be a risk factor for atrial fibrillation in future adult life. And um, this patient with already an atrial surgery but developed this uh, atrial tachy, and in a very unusual location. It's the location is not within the any of the atria, or it was within the junction of the atrial muscle with the coronary sinus os, and at the superior end. In tetralogy of valvar surgeries, so this was like one patient had a critical isthmus between the VSD patch and the pulmonary annulus. So this is the pulmonary annulus and the VSD patch, and the ablation line was drawn between the two, and the other one was the isthmus was seen between the VSD patch and a tricuspid annulus. VSD patch and the tricuspid annulus, and the ablation line was performed. So another 16-year-old boy with TAPUC repair who came with a diagnosis of bradycardia and a heart rate of 40, but the ECG was suggestive of atrial flutter with intermittent 4:1 to 6:1 blocks, and he had atrial flutter going anti-clockwise along the tricuspid annulus, which was ablated by CTI ablation. So, to conclude, atrial and ventricular arrhythmias are getting more common after long term after cardiac surgery or cardiac interventions. The number is increasing, and it will continue to do so. Drug therapy will control but not eliminate the substrate, mainly in the atrial arrhythmias. For the high-risk CHD lesions, follow-up should be very strict, and any such symptoms should be seriously looked into. Catheter ablation is a good therapeutic option mostly for the atrial arrhythmias and occasional ventricular as an adjunct. ICD implantation is the mode of choice for VT or for event of cardiac arrest. Thank you.